Welcome, everybody. I'm Robin Young, publisher of Orthopedics This Week, and welcome to a magnificent new form of a masterclass where the audience is the program. That's you guys, and it's called Ask Lisa. And if you have to ask who Lisa is, you probably have not been to a spinal implant conference. That would be Lisa Ferrara. She was, at one point in her illustrious career, head of the spine research lab at Cleveland Clinic in the 1990s before she left to go start off on her own, and that was Orthokinetics Lab. She is the author of more than 50 peer review articles, more than 30 book chapters. In fact, I think 30 book chapters adds up to an entire textbook. And hundreds, I kid you not, hundreds of podium presentations. Lisa Ferrara is one of the most engaging and fun and knowledgeable podium presenters in our industry. So it is an honor today for me to moderate the first Ask Lisa program. Tonight's topic is SI joint fusion, a very hot topic. I would also point out that our next Ask Lisa program is on facet joint surgery, current concepts, and more, another hot topic. And the one after that is on additive manufacturing, the design revolution. Well, I can tell you, I know this is a hot topic because we had more questions. You guys sent in a ton of great questions, and to answer them and explain everything is the one and only Lisa Ferrara. Lisa, welcome.
Thank you, Robin. It's a pleasure to be here. I've always enjoyed working with you and your colleagues, and I'm excited for these series, and I'm excited
Lisa,
to address SIJ.
If this really turns out well, in future events, we're going to have to talk about the times we were at Castelvi Spine after the meetings, and there's some great stories we'll have to share with the audience if you're ready for that. And incidentally, I should also ask you, because I do think we will have questions left over. Our audience tonight did a really great job of sending in questions. Will you be attending any of the spine meetings this spring, whether it's Castelvi or Think Tank or any of those?
Yes, I will be. I believe I'm going to be at Castelvi's meeting.
Okay.
I have a few, another one in August. I may be at LSRS, Lumbar Spine Research Society, for a day or two. And then, of course, I'll be at NASS.
Of course. Wonderful. Well, why don't we get started? And again, our topic tonight is SI joint fusion. And I'm going to start with a simple, basic question, and that is, Lisa, why is SI joint fusion effective? And, how much stabilization is enough to reduce pain?
Well, Robin, I can address that for you. Hang on a sec. Let me see if I can pull up.
And by the way, guys, all our questions came from our audience. So this is from you guys. So we start with a basic one. Go ahead, Lisa. You have a slide, I think, to throw up here.
I do, because I'm very visual, so I have pictures for everything. Now, it's tough being on camera because you all know I talk with my hands. And so
what do you mean?
it's much more difficult when you're on camera and you can't use your hands to speak, but I'll get through it. All right, so the question regarding why is SI joint fusion, is this the correct one, effective? In order to answer that, you really need to understand the sacroiliac joint, the anatomy of it. And what you're looking at here, I love this picture because it gives you the intense ligamentous structure. It's a large, strong ligamentous band that surrounds the SIJ and obviously the pelvis with respect to torsional stability. A lot of the strength to the SIJ joint comes from this ligamentous complex because it forms a strong band. It transfers the bending moments and the compressive forces that are perpendicular to that SI joint to the pelvis. Furthermore, you've got strong anterior musculature that aids as well is in stabilizing this joint. But what happens is with the strong musculature and the strong ligamentous complex, you also get increased compression across the joint, which is a good thing with respect to its mobility and stability. And you have greater resistance to different forces such as shear forces, bending forces. One thing to think about with respect to that stability is because it's such a strong ligamentous complex and the joint's only 2 millimeters wide, you're going to have very small motions of this joint. And we know this from numerous cadaveric biomechanical tests that have shown very, very little motion for this joint. Let me show you some of the range of motion data that's been measured from numerous studies. In a second, here we go. This is obviously comparing lumbar spinal segment to sacroiliac joint range of motion. But if you look at the range of motion when you're comparing it to the lumbar spine, it is significantly less, significantly smaller than what we see in the lumbar spine. We're seeing flexion and extension about the hip joint. Obviously, we're going to get into nutation and counter nutation with that. That ranges from 2.3 to 4 degrees, which most of the range, median range is about 2 to 3 degrees of rotation. Lateral bending is 1.1 to 1.5, and axial rotation is about 1.7 to as much as 2.9, but it's much, much lower than that. Other studies have shown that it's even smaller. We've got about an average of 3 degrees in flexion extension, about 1.5 degrees in bending, and about 1.5 in rotation. Now, from a translation standpoint, we're only looking at 1 to 3 millimeters. And again, that motion is much, much less. It's also less in the stiffer degenerative, dare I say, older SIJ. Not that I would know, but you can see the difference.
So that was great. It kind of brings to mind a question, especially if I'm used to doing traditional lumbar fusion, interbody fusion. How do the biomechanics differ with the SI joint, an implant for the SI joint, as compared to an interbody device? Again, as you were just saying, lumbar fusion.
Well, they differ quite a bit in many ways. Obviously, both the lumbar spine and the SIJ move about the axes, what we say call 6 degrees of freedom. And I did have a slide kind of showing, I know you're all familiar with the 6 degree of freedom. Actually, it's the one before.
Yeah.
And you can see the rotation about the hip joint, translation from lateral to medial, medial to lateral, as shown on, I don't know if you can see my cursor here on the left side. And that would be across the joint. And then, of course, you've got rotation about what we would say X and Y axes. That's basically the same for both, obviously. But when you go back to the range of motion, the range of motion is significantly different here. As I said, I mean, you're looking at range of motions. And again, there are gender differences. You know, no offense, but the women have known there have been gender differences for many years. But you can see that, you know, the mean range of motion between men and women, it's about 8 or 9 degrees here. And again, it's greater in lateral bending and obviously in rotation. Rotation is kind of within that range, but that's because the lumbar spine doesn't have a lot of torsional rotation, and neither does the SIJ. And we can get into why that is, because with flexion extension and you'll see that there's wedging that occurs where the hips and the iliac crest will wedge towards the SIJ or away from it. And so that contributes to why there's less motion in the SIJ. The nice part about this having less motion is it tends to be more of a stable joint because it does have small motion. But it's almost as if, like I said, the ligamentous complex, the musculature is so strong in the SIJ and surrounding the pelvis, of that pelvic girdle, that it's a self-bracing anatomical design. I always talk about form and function. I know you all have heard me talk about form versus function. I'm an engineer. It's what we do. It's what we believe in. And our anatomy is formed in the same way. It's developed in a manner so that the way that it looks is a way of how it should function. And basically that less motion, the strong ligamentous and musculature lead to an inherently stable joint until it isn't, obviously. And we can talk about that later.
So when the anatomy is, for whatever reason, is changing its form and the function's being compromised and the patient feels pain, and given the unique characteristics of the SI joint, which approach, if I'm going in to try to fix whatever it is, do I go lateral? Do I go posterior? Which of those would be a more biomechanically stable approach?
That is an excellent question. And I've worked a lot on the devices for SIJ, both lateral and posterior, which we call inline. Obviously, it's the same. And it's an excellent question because there's different ways to look at it. Here are some slides I've had looking at both of these approaches. Again, having a lot of experience in both posterior and lateral approach. We're gonna first talk about the structures, right? I feel the posterior approach is a safer approach because it's further away from the neural and vascular structures and not in the plane of entry or exit of the device versus the lateral. Let's see. Here's just a nice visual CT. This is of a cadaver spine. I've the blue box protects the innocent, which is the implant. But I've kind of highlighted the neural structures so you can get a visual of where they're placed and the proximity to the implant. And as you can see, the implant sits much higher than the neural structures within the joint. This is the posterior approach or inline. And it's also angled. Some implants will come up at a higher angle in the posterior approach, projecting downward, and others less of an angle. But you're still far from those neural structures. When you think about the vasculature, again, you're far from the vasculature because you're going to really be in this portion of the implantation of the joint. And you can see it's quite a distance from the vasculature. But if you're taking a lateral approach from the outside in, you're pretty darn close here. And you also need a lot of imaging to visualize where and direct where that tip of that screw or tip of that implant is going. So that's an important thing to think about with respect to not only the visualization and proximity to the vasculature, as well as proximity to the nerves. You've got the superior gluteal nerve here, you've got the sciatic notch here, but at least within the vicinity of the superior gluteal nerves, taking a lateral approach can be risky as well as being near the sympathetic ganglions here. But when you look at this approach, being further away from the vasculature and neurological structures, it appears to be somewhat safer from that approach. Less fluoro would be required because even if it isn't an open procedure from the inline, you still have that visualization and you're further from the eloquent structures. There are other studies biomechanically, and there's been numerous cadaveric studies that have looked at lateral versus posterior or inline approach. And honestly, the cadaveric studies all, for the most part, many of them show no significant difference in the instrumentation or the implantations that's used in the biomechanical stability. And I have data on that, actually.
Wonderful.
1 second, and I'll find the slide.
Yeah, no worries.
Here it is.
There it is.
Luckily, it was
Wow.
blue. I have just a lot of pictures I had and data that I've uploaded so that I can kind of show you these comparisons.
Yeah,
This is
yeah.
Syed et al.'s article. There's a biomechanical study, cadaveric. Now, there's a number of different studies that are done from a protocol design, but most of them, for the most part, are similar with respect to they're tested under some pure moment, most of them pure moment. It comes down to if pubic symphysis was separated or not. But the comparisons I did were all done for the same basically methodology. And here Syed is in line, this data is in line with numerous other data that have done biomechanical cadaveric studies to look at inline versus posterior approach. And again, these studies have shown no significant difference between the posterior or the lateral approach. Usually they do matched pairs where
Mhm.
you'll have a pelvic girdle, one side will get the posterior implant, the other side will get the lateral
Okay.
implant.
Hmm.
And
Hmm.
so what you're
Interesting.
seeing here is flexion, extension, rotation, and bending. There is no significant difference between
Hmm.
any of them. And
That's a
that's
great
fairly
study.
consistent.
Yeah, and it was last year. That's a terrific.
It,
You know,
it is.
so one of our audience members sent in a question, and I don't know the word that he used. So this will be I'm going to learn something. So the question is, she first begins with a statement. Nutation is the nodding of the sacrum in the pelvis. I don't know what nutation means, but whatever it means, does the most stable construct anticipate sacral extension or flexion?
Ooh, excellent, excellent question. Okay, so first, let's explain notation. And again, I have pictures. I
So,
hope it
team,
works.
yes, please. By the way, these are great pictures. I just want to say that these are
Oh, thank you.
terrific.
I figured if I can't use my hands,
Well,
then I have to
look,
use
I mean,
pictures.
well, and when the power goes down, you have to just do hand pictures. So,
Exactly.
all right.
Okay, so let me first show you, I'm gonna see if this works. Nutation, which is really nodding of the sacrum.
Oh,
Can you see it
yeah,
moving?
yep, 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 yep.
Okay, I just thought that was kind of neat. Um,
Hmm.
Okay, but now let's explain it. What is counternutation and what is nutation? Basically, it's movement of the sacral bone with respect to the iliac. What does it mean? Well, when your lumbar spine goes into flexion, you go into counternutation. So as your spine bends forward, your lumbar spine, your sacrum moves back. It basically rotates and shifts back or posteriorly with respect to the iliac bones. The reverse is true for extension. When you go into extension, shown here, your sacrum moves forward. It kind of rotates forward, and then the tailbone would rotate out because the top part comes in, the tailbone moves out. So it's kind of an angular motion here. Now, what does that mean? Well, taking it from both views here, a side view and a front view, when you go into nutation, which is extension of the spine, you get not only, we said the sacrum moves forward, you get this, yeah. I have to go back and forth between nutation and counter nutation. So nutation is extension, sacrum
Hmm.
moves
Hmm.
anteriorly. As you can see here, tailbone moves out. That's side view. But looking at the anterior or front view, you also get what we call wedging of the iliac bone. Basically, they move inward on top towards the sacrum here and here. That's why there's two little stars. And they move outward where the
So,
pubic symphysis is.
yeah.
They separate. This is important. Why
Hmm.
is it important? Well, because now you're compressing that joint superiorly on the sacrum. Inferiorly, it's spreading open in the nutation. And your
So
forces are going to be higher.
what are the implications of all that on the construct? Uh, so to really deliver stability, do you anticipate one of those two things, either extension or flexion?
I would anticipate for flexion because for stability, they move away in flexion because your sacrum moves posteriorly. So you want to make sure, and in counter nutation, they describe it as you experience it in cases like lying down and trying to get up from a lying down position. You're in counter nutation. So now you're, dare I say, offloading the implant. If you're seating the implant in this region, you could be slightly offloading it because your iliac spread away from the joint. Now you're spreading that joint, distracting it just through motion, obviously. So you want to make sure that you're stabilizing for that condition. Again, being careful that you don't overload it too much because you're going to load it in extension or nutation of the joint. Flexion and extension, though, of the lumbar spine, which leads to nutation and counter nutation or counter nutation of the sacrum, is the largest motion, the largest loading as well on the SIJ. And that's the motion you want to, like we do in the lumbar spine, flexion extension is kind of that motion. We want to make sure we're stabilizing and when using a
Right.
cage, for instance.
Is it also the largest source of pain, by the way? Just it would seem so intuitively.
I believe so, yes.
Okay. So let's look at the biomechanics uh, of the posterior allograft distraction, compare and contrast those biomechanics. So compare and contrast the biomechanics of posterior allograft distraction, posterior oblique, lateral oblique fusion. So you got a choice: allograft distraction or fusion.
Yeah, I thought that was interesting. Okay. So are
Yeah.
you saying, when I saw the question like allograft distraction, I mean, a lot of the allografts, a lot of the implants that have come out now are approximately within the same size as the allografts that have been used. And so it's almost like you're implying that all the implants are distracting, and that's not true. And you don't want your implants to distract.
Good point.
So, that's why
Very
I make the
good.
big
Very
bucks.
good. I love it. That's great.
But you
So,
don't want
don't want it. Okay. So, where's the center of rotation?
that.
That's
Okay, I
probably a
have
trick
pictures for
question.
this one.
Sorry. Oh,
No,
good.
that's
Yes.
okay. And we can talk about the implantation later. Let's see if I can
Yeah.
advance my
Yeah.
slides.
Sure.
I have
You
lovely
do have big
pictures.
slides. I do love those. Yeah, you got it all there. I'll
Thank
tell you,
you.
everyone should make
Oh,
sure to see you at your next podium presentation. They can grab you afterwards and ask more questions. This is great. Okay. Sorry.
thank you. Okay, so what you're looking at here, sorry, I have to minimize you for a second, is the sacrum, the SIJ, excuse me, in extension for intact motion, no implant. And what you're seeing is the axis of rotation or the plane of rotation and the point of rotation. And I love this because pictures make it so much easier to try to explain center of rotation and rotation. It's complex enough, but this work was done by Panico et al. And the references below. And it's lovely because you also see the stress patterns. Now, for those of you that are not familiar reading finite element analyses, red has highest bone mesostress. So the highest stresses are seen yellow, orange, red. The lowest are in the blues and light blues. But when you look at the center of rotation, you're noticing that it's actually further down the sacrum posteriorly
Yeah. Yeah.
here. Now let's go, next slide. Maybe if it wants to, there we go. Inflection. First of all, less stress, not as red here. I think the last one was 0.85, this is 0.9, but less stress, less red. Still, you've got a similar center of rotation, shifted slightly, not much. And then the plane of axis is different, obviously, because you're going about that joint. And I can go back. Extension, notice your plane. It's somewhat of an oblique plane and it
Right.
changes with increased load. Your center of rotation shifts a little bit higher at higher loads. See that? Lower, and then it moves to a higher load. Now let's go to flexion. Stays about the same across,
Pretty consistent. Yeah.
and the plane of rotation is pretty consistent. Now, the exciting part, when you're bored on a Saturday night, now you add instrumentation, and I've given a lot of lectures on how the COR changes when you're adding instrumentation for fixation. If you look at the above, they did this for, I believe this is, the intact pedicle screws, S2 alar iliac screws. So intact pedicle screws, S2 AI, and then two other systems with the lateral screw and a lateral screw without the S2 AIs. But if you look at intact, your COR, the minute you add pedicle screws, which surprised me, I thought it would have shifted a little. It just becomes a little more focused. Stress doesn't change as much. But then you get it shifting more anterior when you put a lateral screw, which makes sense to me because we see this even cervical spine when you're doing a cage and a plate. You start to shift your COR closer or between the
What a
two.
difference. Yeah.
And then, of course, you add the alar iliac screws with a lateral, and it changes it and makes it much more anterior because you've got the screws more anterior here. And that's how it changes. And this is all at the highest loads that you're seeing, or moments, 7.5 newton meters.
That is a terrific. I love that slide. That probably leads us into the next question, which is where's the main concentration of forces?
Well, Alec, actually, the main concentration of forces, are you talking about the intact joint more so?
The question just came in like that. So let's go with
Okay, we'll do
intact
it for
joint for
both.
now, but then take it from there.
Okay. Where you're going to see the main concentration of forces, let's see. I'm going to go back to my spine wall. I don't have a picture for this because you really see it in what we call vertical shear and compression across the joint. So what I'll do is go back to
That makes
my
sense.
anatomy again.
Yep.
Wonder if this is a good one. Okay. So the main concentration of forces in the SIJ is obviously going to be compression across this joint, as well as what we call vertical shear. And vertical shear is basically along this joint this way, so that you're coming down and it's kind of shearing. Your vector is here, but it's really along the joint, so that the joint would picture it shearing vertically, where this side stays fixed and this one moves down, but it moves obviously along that joint, which is difficult to do knowing the anatomy. It's almost like an interlocking puzzle piece, the way the SIJ is.
Right.
Let me see if I've got a cross section of it. Sorry if I'm making you sick.
Yeah, no, that's
Oh,
okay.
this one. The unique part is when you look at this joint, and we're gonna, we can talk about this. This is the ligamentous complex, but look at the gap here. This is a transaxial section through a pelvis. And I love this, this slide because it helps you visualize that posterior instrumentation and where it sits. But the angle of this joint, especially when it degenerates, it gets even more of a 90-degree curvature here, which makes it so difficult to really approach this region, instrument something that would go along the entire joint. But this is where all your motion would be because of that ligamentous structure. However, your forces are going to be high
Yeah.
when you're looking at the shear vector, which would be along this region, and then the compression here.
That is terrific. I love that. It's good. Uh, so I got two more questions, these are both. I'll call the next one, the acid test question.
Oh,
Okay, you know, move everything aside. Let's get to the real issue.
okay.
Are there definitive tests for determining if SI fusion will address a patient's pain issues, and what are the primary pain generators?
That's a great question. Because it's interesting. I've gone through a lot of the literature, and do we have an exact answer? There's definitive tests from what the literature says, but I think there's also literature that would present other tests as well as why does it happen? Why is there pain? So I do have pain slides because this question's asked a lot, actually. And it's always interesting at meetings to kind of hear the debates that go on.
Indeed, indeed.
Oh, let me go back.
This is a great one. Oh, this is a cool. Oh, wonderful.
Okay. I love this one because you know me,
Mhm.
I have to put in the mechanics. If it isn't about force and motion,
Oh,
you'll lose me. But the mechanism of SIJ is a combination of that axial loading and an abrupt rotation when you get pain. But pain's due to a number of different pathologies, and I've got a few slides here. And something you have to think about too, we always talk about adjacent segment disease, but it's true for the SIJ. We see it in lumbar spine, but guess what? If you increase angular motion and stresses across that SIJ, it can actually be correlated with adjacent segment disease you might see in the lumbar spine and vice versa. So again, I always talk about biomechanics as a system. It's not just the lumbar spine or just the hip. You've got a whole SIJ, and stress travels. So it's going to travel. If you change the loading in the lumbar spine, it'll change the loading on the SIJ. It'll change the loading on the hip. So I was asked if, physicians and surgeons, clinicians are looking at the system. Is it the lumbar spine? Is it the SIJ? Is it the hip? Or is it all of the above? When we look at the pain distributions, a lot of them can mimic SIJ pain, some of the diseases, and a lot actually will mimic lumbar spine pain. And these are just a few here. But there are many, many, many pathologies as to why you have SIJ pain. And there's quite a few that I had pulled up. Everything from degenerative arthritis to,
right.
myofascial issues, et cetera. And even more, less frequent metabolic endocrine disorders, et cetera. When we think about pain, some of the literature says that clinical examination alone cannot definitely confirm that SIJ is the source of patient's pain. And we see this and we hear about it at the meetings, but there are tests, pain provocative tests, palpation tests, and motion demand tests. The palpation tests are okay. Again, there's going to be some controversy there if you're really detecting that pain. But when you start to get into the motion demand test, that helps even further identifying the source of pain. That's the most important part because it can be masked either as a lumbar spine pain or hip as well. But also imaging is obviously going to help. The x-rays, the CT, MRI, bone scans that don't provide the consistent findings, but they can be used to help diagnose SIJ pain.
Absolutely.
And again, it's
Absolutely.
always the whole story, doing multiple to address that.
That's a great answer. That is absolutely right. Now, we have a final question, which I think will be the most fun question of all. And I'll just read it as it came in from our audience. Since most systems available are fixation only, is it possible to get FDA to distinguish them from systems that actually perform? I added with emphasis added. Dr. Farrar,
Nice. That was,
address this important question.
okay. Repeat the question again.
Since most systems available are fixation only, is it possible to get FDA to distinguish them from systems that actually perform?
Ooh, ooh. I love when I get loaded questions.
That's a loaded question, isn't it?
Totally love it. Well, first I want to say they're all fixation systems. I think you mean stabilization only. Or
I think you're
it's
right.
either fusion or stabilization, right? That when you think
Mhm.
of the regulatory, how they classify it, I mean, how they label it. Okay, so
Yeah.
thinking like stabilization only, is it, can you can we distinguish between systems that actually perform?
Mm.
That's a good one. I would say yes, we can. You won't like the answer. You have to prove it. Prove to me.
Amen.
Why should I believe you, right? Again, it all comes down to that. It's a court of law. Why should I believe you? You have to prove it. Show me the evidence, human data.
Where's the beef?
Yeah,
Yeah. Where's the
exactly.
beef?
I
I
love
want
it.
data. Come on.
Show me the data. And
Show me
that's,
the data.
show me the data. And you know, it- to be honest, I like the fact that your best marketing is show me the data. Give me
So
something that I can sink my teeth into and say, all right, this makes sense. I get this. This is why this performs. Um, so you can make it look all pretty, but it's just about the data. And so you do
thank
have to think about it in studies.
I think that is a ideal way to end our program. And I just want to say we had, I think, another 15 questions. So we will definitely be
Oh,
doing a part two. Folks, make sure you get yourself to Castelvi Spine. You can see Lisa there. There's some other meetings, certainly at NAS. Make sure you get there. And Lisa will be presenting, and she's always available when you get there. Our next Ask Lisa program, again, will be on facet joint surgery. That's going to be really, really interesting, current concepts and more. And of course, the one thing, this additive manufacturing explosion, freedom to express. Does it make any difference? Well, Lisa is going to have that all scoped out. She's got the answers, whether you like them or not.
I
She's got the data. All right,
love it.
Lisa, you are the best. I really appreciate this. I can't wait to do our next one. And audience, you send in some magnificent questions. Keep it up. We look forward to the questions you've got to ask about facet joint surgery and, of course, additive manufacturing. And that's all for the first Ask Lisa. Thank you, Lisa. It was
Thank you,
great.
Robin. It was a pleasure. It was a pleasure. I'm
And
looking forward to
and
it. You know, I
audience,
love the sets.
oh, I know. Well, we have no shortage of great topics. I'll tell you that. All right.
Definitely.
Well, thank you, everybody. Have a good evening, and we'll see you next time.
Thanks, everybody. See you.